Hello, this is Mrs. Page, and this is part 2 of cardiac dysrhythmias. In this part, we will start getting into the actual dysrhythmias. A dysrhythmia is a disorder of rate and rhythm due to either the SA node not firing as the pacemaker or a block in the impulse through conduction. Nursing interventions related to dysrhythmias will focus first on assessing the patient because remember, not all dysrhythmias seen on the monitor are correct. They can be artifact from the patient moving or the electrodes might not be attached properly. You'll want to assess for signs and symptoms of decreased cardiac output, such as cool, clammy skin, decreased urine output, faint peripheral pulses, and dyspnea. There are different categories of dysrhythmias. Dysrhythmias originating in the SA node include bradycardia and tachycardia. Atrial dysrhythmias include premature atrial contractions, or PACs, supraventricular tachycardia, or SVT, atrial fibrillation, or A-fib, and atrial flutter, or A-flutter. Ventricular dysrhythmias include premature ventricular contractions, or PVCs, ventricular tachycardia, VT or V-tach, ventricular fibrillation, VF or V-fib, Asystole, and Pulseless electrical activity or PEA. We will also go over Atrioventricular blocks, and those include first degree AV block, second degree type 1 AV block or Mobitz type 1 block or wenckebach, second degree type 2 AV block or Mobitz type 2 block, and third degree AV block or complete heart block. We will first start off with dysrhythmias originating in the SA node. Sinus bradycardia essentially looks like normal sinus rhythm, except the heart rate is less than 60 beats per minute. So let's interpret the EKG using the 8-step process. The rhythm is regular because each of the R to R waves are spaced out evenly. The rate will be 40 beats per minute because there are 4 R waves. If you multiply that by 10, it gives you 40 beats per minute. The P waves are round and upright and equal throughout. The PR interval, there are 5 small squares. If you multiply that by 0.4, it gives you 0.20 seconds, which is in normal range for our PR interval. The QRS complex is about 2.5 squares. If you multiply that by 0.4, it gives you 0.10 seconds, which is within our normal range for our QRS complex. Our ST segment, if we draw a line across, is on the isoelectric line. Our T waves are round and upright, not peaked or inverted. And our QT interval is about 10.5 small squares. If you multiply that by 0.04, it gives you 0.42 seconds, which is within normal range for our QT interval. I've included a chart on this slide that you can fill in with causes, signs and symptoms, and treatment. Causes of bradycardia can be from physical fitness, medications, MI, sleep, vagal stimulation, hypothermia, vomiting, or hypothyroidism. Signs and symptoms are rarely shown unless the bradycardia is decreasing cardiac output. That would be called symptomatic bradycardia because the patient is showing symptoms of bradycardia. Some signs and symptoms you might see is syncope, lightheadedness, and fatigue. If the patient is asymptomatic, there will be no treatment, but if the patient is symptomatic, you want to treat the cause. If the cause of the bradycardia is from medications, then stop the medications. If treating the cause doesn't work or the cause is life-threatening, atropine is the drug of choice for bradycardia, and a pacemaker can also be used to help maintain the heart rate. Sinus tachycardia looks like normal sinus rhythm, except the heart rate is greater than 100 beats per minute. So we can interpret this strip using the 8-step process. The rhythm is regular because our R to R interval is spaced out equally throughout the strip. There are 13 R waves in this 6-second strip, so we can multiply that by 10, and that gives us 130 beats per minute. Our P waves are round and upright and equal throughout. Our PR interval is about 3 squares. If we multiply that by 0.4, that gives us 0.12 seconds, which is within normal range for our PR interval. Our QRS complex is about 3 squares. If we multiply that by 0.4, it gives us around 0.12 seconds, which is within normal range for our QRS complex. Our ST segment is on the isoelectric line. Our T waves are not peaked or inverted, they are round and upright throughout the entire strip. And our QT interval is around 8 small squares. If we multiply that by 0.4, it gives us 0.32 seconds, which is within normal range for our QT interval. Causes of tachycardia include anything that causes an increased demand for oxygen, such as physical activity, anxiety, pain, fever, hemorrhage, shock, MI, hyperthyroidism, hypothermia, heart failure, excessive caffeine, and tobacco use. Remember, increasing the heart rate increases the amount of oxygen delivered by increasing the amount of blood that is circulated. Signs and symptoms usually include palpitations, angina, and dyspnea if the heart rate is elevated and sustained. The treatment is going to be to treat the cause. If treating the cause, such as stop intaking excessive caffeine, stop using tobacco, fixing hyperthyroidism. If treating the cause doesn't work, digoxin or cardizem can be given to slow the heart rate. We will now move on to atrial dysrhythmias. Premature atrial contractions, or PACs, occur when the atrial tissue becomes irritable. Before the SA node can fire an impulse, an irritable atrial focus jumps in, firing its own impulse, which causes an early heartbeat. PACs usually look like an early P wave, and the P waves won't match out to be regular. And the P waves usually on PACs will look abnormal. The P wave can also be lost in the T wave, making the T wave look bigger or have an extra bump. A PAC is usually followed by a pause. PACs can occur in bigeminy, meaning every other beat is a PAC, can occur in trigeminy, meaning every third beat is a PAC, or it can occur in couplets, meaning 2 PACs are in a row. So let's go ahead and interpret a strip. So we can see that the rhythm is irregular because the R to R intervals are not evenly spaced out throughout the strip. The rate is 60 beats per minute because there are 6 R waves within our 6-second strip. P waves are round and upright throughout until the abnormal PAC occurs. Our PR interval is about 3 small squares. Multiply that by 0.4 gives you 0.12 seconds. Our QRS complex is about 2.5 squares. Multiply that by 0.4 and it gives you 0.10 seconds, which is within normal range for our QRS complex. Our ST segment comes down to the isoelectric line. Our T waves are upright. They are not peaked or inverted throughout the entire strip. And our QT interval is about 11 squares, small squares. If you multiply that by 0.4, it gives you 0.44 seconds. Our interpretation of this strip would be normal sinus rhythm with PAC. Causes of PACs can include stress, fatigue, anxiety, inflammation, infection, caffeine, nicotine, alcohol, medications like epinephrine, amphetamines, or digoxin. It can also be caused from myocardial ischemia, hypermetabolic states, and electrolyte imbalances. Signs and symptoms include heart palpitations, but oftentimes PACs are unnoticeable. The treatment is to treat the cause, such as eliminating the causative factors, amphetamines, nicotine, caffeine, alcohol. If this doesn't help, anti-dysrhythmic medications can be used. If PACs occur frequently, they can lead to a more serious atrial dysrhythmia. It's important to teach the patient to manage stress and substances to avoid, like caffeine and alcohol. Supraventricular tachycardia, or SVT, is a sudden increase in heart rate between 150 and 250 beats per minute. Impulses driving the rapid rhythm originate above the ventricles. P waves might not be visible because the heart is beating so fast that the P waves are embedded in the T wave. It's called paroxysmal supraventricular tachycardia when the rhythm is intermittent, so the patient will go into SVT, then come out, and then go back in. Let us interpret a strip. When looking at the R to R intervals, we can see that this rhythm is regular. There are 20 R waves on this 6-second strip. We multiply that by 10, and that gives us 200 beats per minute. Our P waves are almost hidden in the T waves. You can see this little notch right here. So our P waves and our T waves are kind of intermingling right here. Our PR interval is about 2 squares. Multiply this by 0.4 gives you 0.8 seconds, which is a shorter PR interval than normal. Our QRS complex is about 3 small squares. If we multiply that by 0.4, it gives us 0.12 seconds, which is within normal range. Our ST segment comes back down to the isoelectric line. Our T waves are distorted by P waves, and our QT interval is about 5 small squares. If you multiply that by 0.4, that gives you 0.20 seconds, which is considered a shortened QT interval. Our interpretation for this strip is supraventricular tachycardia, or SVT. Causes of SVT include drugs, alcohol, stress, smoking, hormone imbalance. It's common in young people, especially in women. Signs and symptoms include angina, palpitations, lightheadedness, dyspnea, anxiety, and altered level of consciousness. Treatment includes eliminating the cause. Usually the first treatment for SVT will be some type of vagal maneuver, such as the carotid sinus massage, asking the patient to bear down, asking the patient to cough. There's also the dive reflex, where you splash ice cold water on the face. If those don't happen, or if those don't work, antidysrhythmics can be used. The main one that is used is adenosine. This is given over a few seconds and flushed immediately. This is going to cause a flat line on the EKG monitor, and then if the adenosine works, it will switch to normal sinus rhythm. If the adenosine doesn't work, they will try beta blockers and calcium channel blockers. Synchronized cardioversion can also work, and radiofrequency catheter ablation can be used as well. Atrial fibrillation is caused from multiple rapid impulses from many different atrial foci in a totally disorganized manner. So essentially the atria are quivering. The atrial rate can range from 350 to 600 beats per minute, and the ventricular rate is usually 120 to 200 beats per minute. They might also have A-fib with RVR, or rapid ventricular rate, and that's where you get the ventricular rate of above 100. On A-fib, there are no clear P waves. There are no atrial contractions. There's a loss of that atrial kick, and there's an irregular ventricular response. So this irregular ventricular rate will decrease ventricular filling, and that causes reduced cardiac output. Because the atria are quivering, this allows the blood to pool in the atria, and this can cause clots, which puts the patient at risk for stroke, heart attack, DVT, or PE. Let's go ahead and interpret a strip. Looking at our R to R interval, we can go ahead and see that this rhythm is irregular. Our rate, specifically the atrial rate, is indiscernible, whereas our ventricular rate, looking at our R waves, is 120 beats per minute. Our P waves are replaced by fine fibrillatory waves, and our PR interval is going to be indiscernible because we can't really see a P wave. Our QRS complex is about 1 square, which is 0.4 seconds, which is short for our QRS complex. Our ST segment comes back down to the isoelectric line. Our T waves are also indiscernible. The T waves are replaced by those fine fibrillatory waves. They're lost in there. And our QT interval is also going to be indiscernible because we can't find our T waves. Interpretation of this strip is going to be atrial fibrillation. Causes of atrial fibrillation include rheumatic heart disease, CHF, hypertension, PE, aging, cardiac surgery, and COPD. Signs and symptoms will include heart palpitations, dyspnea, and angina. Complications of A-fib can include a thrombus formation from the blood being stagnant in the atria, which can then be pushed out into the blood flow, can cause stroke, MI, PE, DVT. Treatment for A-fib will include digoxin, beta blockers, calcium channel blockers, or antidysrhythmics such as amiodarone. Heparin or warfarin will be prescribed to prevent thrombi in the atria becoming emboli. Cardioversion, which is a synchronized electrical shock to stop the atria from quivering, can be given. For example, if a patient comes into the ER with A-fib with RVR, they will more than likely be put on a cardizem drip. If this doesn't help, they might try a different drug, or they might try cardioversion. A patient with chronic A-fib will either take digoxin, cardizem, or amiodarone to control that ventricular rate. A patient might stay in A-fib chronically, or they might go back and forth into A-fib and normal sinus rhythm. So that's why anticoagulants are important for these A-fib patients. Atrial flutter, or A-flutter, is when there are abnormal P waves that produce a saw-toothed appearance. In A-fib, the atria are quivering. In A-flutter, the atria are beating, but rapidly, around 250 to 300 beats per minute. There will be more than one P wave before each QRS, and because the atria are beating so rapidly, not every impulse will get sent to the ventricles, so you'll see an irregular ventricular rate. Let's go ahead and interpret a strip. In this specific strip, the rhythm is regular. Atrial and ventricular rhythm is regular. Not all the time will you have atrial flutter that has a regular ventricular rate. The rate for the atrial is 270 beats per minute. Our ventricular rate is about 70 beats per minute. Our P waves are sawtoothed in appearance, and our PR interval is unmeasurable. Our QRS complex is about 1.5 small squares, so that's 0.0 seconds. Our ST segment is unidentifiable because there are no T waves that we can really see. All of these sawtoothed appearance are our P waves. Again, T waves are unidentifiable, and our QT interval is going to be unidentifiable as well. Our interpretation of this strip is atrial flutter. Causes of atrial flutter include anything that enlarges the atrial tissue and elevates atrial pressures, such as heart failure, mitral valve disease, hyperthyroidism, alcoholism, rheumatic heart disease, MI, COPD, or PE. Signs and symptoms can vary. If the ventricular rate is normal, there will probably not be any signs and symptoms. If the ventricular rate is increased, then the patient will have signs such as palpitations, dyspnea, and angina. Treatment for A-flutter is synchronized cardioversion unless the patient has been in A-flutter for more than 48 hours. If you cardiovert a patient that has been in A-flutter for more than 48 hours, it runs the risk of throwing a clot, so the patient needs to be properly anticoagulated before being considered for cardioversion after 48 hours. And the same thing will apply for A-fib. Medications used for atrial flutter include digoxin, propranolol, and amiodarone. These medicines are used to help convert that rhythm. A pacemaker might also be used as treatment. Now we will move on to ventricular dysrhythmias. Premature ventricular contractions, or PVCs, are wide, bizarre QRSs with no P wave. Different types of PVCs can occur. A unifocal PVC is when all PVCs look the same. A multifocal PVC is when the PVCs look different, which you can see on this top strip. Bigeminy is when a PVC occurs every other beat, which you can see on the bottom strip. Trigeminy is when a PVC occurs every third beat, which you can see on the top strip. And a couplet is when two PVCs occur together, which you can see demonstrated in the bottom strip. Our rhythm for when we have a PVC is regular until we get to that PVC, so it is going to be considered irregular. The rate is going to be 70 beats per minute, and you will count the PVC because it is a ventricular contraction. P waves are going to be absent with the PVC, but they will be present with all the other QRS complexes. Our PR interval is about 0.14 seconds, which is within normal limits for a PR interval. Our QRS complex is around 0.08 seconds, except for that PVC. Our ST segment is on the isoelectric line. Our T waves are upright, except the T wave that is with the PVC, and we can consider that T wave peaked. And our QT interval is around 0.36 seconds. So our interpretation of this strip is going to be normal sinus rhythm with PVC. Causes of PVCs can include hypoxia, caffeine, alcohol, low potassium, MI, exercise, or stress. Signs and symptoms: the patient may or may not have any signs and symptoms, but if they do, it will include palpitations, lightheadedness, fatigue, and they can have decreased cardiac output if there are frequent PVCs. The treatment will depend on the type and number of PVCs. You'll treat the cause, so if potassium is causing the PVCs because they are hypokalemic, then the patient will receive potassium. Lidocaine or amiodarone can be given to treat PVCs, and oxygen needs to be applied if there are signs and symptoms of decreased cardiac output. Ventricular tachycardia, or VT or V-tach, is life-threatening. This is when the ventricles become the pacemaker of the heart. There are no P waves. The QRS complexes are wide and bizarre. The ventricular rate is greater than 100 with 3 or more irregular beats in a row. Monomorphic V-tach is when they have a uniform shape, which you can see on the top strip. Torsades de pointes is a type of polymorphic V-tach, and translation from French, torsades de pointes means twisting of peaks. So you can see on the bottom, the QRS complexes kind of rotate around the baseline. They deflect downward and upward. When interpreting a rhythm of V-tach, we can go ahead and see that the rhythm is regular. The rate is around 180 beats per minute. The P waves are absent because with V-tach, the ventricle is the pacemaker. Our PR interval is unmeasurable because we don't have any P waves. Our QRS complex is wide and bizarre. The ST segment is unmeasurable because we don't have any T wave and it doesn't come back down to that isoelectric line. Our T waves are hidden in that QRS complex, and our QT interval is therefore unmeasurable. So our interpretation is ventricular tachycardia. Causes of V-tach include MI, hypoxemia, low potassium, or digoxin toxicity. V-tach is a major cause of sudden cardiac death, and it's always deadly without intervention. Signs and symptoms will depend on if it is sustained V-tach. That will cause decreased cardiac output, hypotension, loss of consciousness, cool, clammy skin, and angina. Might also see palpitations, lightheadedness, syncope, anxiety, hypotension, and tachycardia. Treatment will depend on if there is a pulse or no pulse. If there is no pulse, it is considered pulseless V-tach, and the treatment for that is immediate defibrillation and CPR. If the person has V-tach with a pulse, then the treatment is synchronized cardioversion. You'll also want to correct the cause, if it's caused by electrolyte imbalances or ischemia. Medications such as amiodarone, lidocaine, beta blockers can be used, and they will follow the ACLS protocol. If the patient has recurrent episodes of V-tach, they might be considered for an implanted defibrillator. Ventricular fibrillation, VF or V-fib, is life-threatening, and it's electrical chaos of the ventricles. Impulses from many different foci are firing, and ventricular contraction is not occurring, so there's no cardiac output or pulse. No cardiac output means no perfusion to the brain, heart, or body, and it can be fatal if it's not treated within 3 to 5 minutes. There are 2 different types of V-fib that you can see. Fine V-fib, which is shown in the top strip, and coarse V-fib, which is shown on the bottom strip. Interpreting a strip of ventricular fibrillation, or V-fib, we can see that the rhythm is chaotic. The rate is unmeasurable because we're not having those complete beats of the ventricle. They're just quivering. Our P waves are absent. Our PR interval is unmeasurable. Our QRS complex is indiscernible. Our ST segment is not applicable because we don't have P waves, T waves. T waves are indiscernible, and our QT interval is unmeasurable. So our interpretation of this strip is ventricular fibrillation, and we can further put this into the coarse ventricular fibrillation category. Causes of V-fib can include MI, electrocution, high potassium, drowning, and hypothermia. Signs and symptoms include no cardiac output, no pulse, no respirations, no level of consciousness, and no blood pressure. Treatment is immediate defibrillation. You can think defib the V-fib and CPR. Meds will be given according to the ACLS protocol, such as epinephrine, amiodarone, or lidocaine. Asystole is complete absence of electrical activity of the ventricles. You might sometimes see the atria contract and a P wave, but there is not a QRS complex that follows. This is also known as flatline. The cause includes myocardial hypoxia, untreated V-fib, and severe hyperkalemia. Signs and symptoms are full cardiac arrest, so no pulse, no breathing, no blood pressure. Treatment is CPR, ACLS protocol for asystole, which consists of epinephrine, atropine, and eventually intubation. And again, you cannot shock this patient because there is not any kind of electrical activity to shock. Pulseless electrical activity, or PEA, is when there are electrical impulses of the heart, but the cardiac muscle is not contracting. It can look like a normal EKG, but the patient will not have a pulse. Causes include hypovolemia, hypoxia, acidosis, tension pneumothorax, cardiac tamponade, PE, hypothermia, MI, or overdose. Signs and symptoms include no pulse, no blood pressure, and treatment includes CPR and epinephrine, and following that ACLS protocol. Next, we will talk about atrioventricular blocks. An AV block results from an interruption in the conduction of impulses between the atria and the ventricles. So essentially, the atria and the ventricles aren't communicating like normal. Causes can include MI, digoxin toxicity, myocarditis, calcium channel blockers, beta blockers, cardiac surgery, aging, and congenital abnormalities. With our first-degree AV block, the impulses from the atria are consistently delayed during conduction through the AV node. So it's as if people are walking in a line through the doorway, but each person hesitates before crossing the threshold. It will look like normal sinus rhythm, but the PR interval is longer than normal, so it'll be greater than 0.20 seconds, and it will be consistent. We'll go ahead and interpret a strip for our first-degree AV block. We can see that the rhythm is regular. Our rate is 50 beats per minute. Our P waves are around and upright. Our PR interval, you can see it's longer. It is about 8 seconds. If you multiply that by 0.4, that gives you 0.32 seconds, which is a longer than normal PR interval. Our QRS complex is about 2.5 small squares. If you multiply that by 0.4, that gives you 0.10 seconds, which is within normal limits. Our ST segment is isoelectric. Our T waves are not peaked or inverted. And our QT interval is around 9 small squares. Multiply that by 0.4, and that gives us 0.36 seconds. And our interpretation of this is going to be a first-degree AV block. Causes include MI, myocarditis, degenerative changes in the heart, hypertension medications, and digoxin. Signs and symptoms usually only occur if cardiac output is affected, which is usually rare. So your patients that have first-degree AV block can usually be okay with this rhythm. Treatment is going to be to treat the underlying cause. Second-degree type 1 AV block, or Mobitz type 1 or wenckebach, is when each impulse from the SA node is delayed slightly longer than the previous impulse until an impulse fails to be conducted to the ventricles and it drops. You can remember type 1 second degree AV block as longer, longer, longer drop, which rhymes with wenckebach. The PR interval gets gradually longer until a P wave fails to conduct to the ventricle, and when that P wave fails, that is considered your dropping. When interpreting a strip of a second degree type 1 AV block, we can see that the rhythm is not regular. Our R-to-R intervals are not spaced out regularly. The rate for the atrium are about 50 beats per minute, whereas our ventricular rate is 40 beats per minute, because we can remember that ventricular beat is dropped. Our P waves are round and upright, but when looking at our PR interval, we can see that it progressively gets longer and longer until finally it drops that ventricular beat. Our QRS complex is about 3 small squares. Multiply that by 0.4 and it gives you 0.12 seconds, which is within normal limits. Our ST segment comes back down to that isoelectric line. Our T waves are upright, they're not peaked or inverted, and our QT interval is around 9 small squares. Multiplied by 0.4 gives you 0.36 seconds, which is within normal limits. So our interpretation of this strip is type 1 second degree AV block, or Mobitz type 1 or wenckebach. Causes can include an inferior wall MI, coronary artery disease, rheumatic fever, hypertension medications, or vagal stimulation. Signs and symptoms will show if there is decreased cardiac output. If there is decreased cardiac output, you'll see signs like lightheadedness or hypotension, especially if that ventricular rate is slower. If asymptomatic, no treatment is necessary, but atropine can increase conduction and a pacemaker can help long-term relief. Second degree type 2 AV block or Mobitz type 2 is when there are occasional impulses from the SA node that fail to conduct to the ventricles. There is consistent AV node conduction with an occasional dropped beat. So the strip will look like someone erased some of the QRS complexes, and the P waves will remain regular. Interpreting a strip for second degree type 2 AV block, with our rhythm, we can see that the atrial rhythm is regular, but our ventricular rhythm is irregular, and that's because one of our ventricular beats got dropped. Our atrial rate is 70 beats per minute, whereas our ventricular rate is 50 beats per minute. Our P waves are round and upright. Our PR interval is about 3 small squares. Multiply that by 0.4 gives you 0.12 seconds, which is within normal limits, except when our QRS complex is dropped. Then we have a prolonged PR interval. Our QRS complex is about 2 small squares. Multiply that by 0.4 gives you 0.8 seconds, but again, some of the QRS complexes are dropped. Our ST segment comes back down to the isoelectric line. Our T waves are upright, not peaked or inverted, and our QT interval is around 8 small squares. Multiplied that by 0.4. That gives you 0.32 seconds. And our interpretation of this strip is type 2 second degree AV block or Mobitz type 2. Causes of second degree type 2 AV block include usually an anterior wall MI, degenerative changes of the conduction system, so aging can cause this, and coronary artery disease. Signs and symptoms: as long as the cardiac output is maintained, the patient will usually be asymptomatic. If the patient is continuously dropping these QRS complexes, the patient will experience palpitations, fatigue, dyspnea, chest pain, or lightheadedness because, again, those ventricles are not beating. We're losing that ventricular beat, so blood is not getting to the body. Treatment is observation if it's not detrimental, so if they're not having that decreased cardiac output. But atropine, dopamine, or epinephrine can help increase cardiac output, and they might need transcutaneous pacing. Third-degree AV block, or complete heart block, is when the impulses from the atria are completely blocked at the AV node, and they can't be conducted to the ventricles. So this is essentially like a line of people trying to go through the door, but the door is locked and the people can't get through. The EKG strip will look like a strip of P waves laid independently over top of a strip of QRS complexes. So a P wave doesn't conduct a QRS that follows it. So the P wave is regular and the QRS are regular, but they aren't communicating with each other. When interpreting a strip for third-degree AV block, we first need to look at our atrial beats, which is our P waves. We can see that those are evenly spaced out, and then we can look at our QRS complexes, which is our ventricular rate. We can also see that those are evenly spaced out, but the P waves and the QRS complexes are not talking to each other. There is no coordination between the two. So we have a regular atrial rhythm and a regular ventricular rhythm, but they're not communicating. Our atrial rate is 120 beats per minute, whereas our ventricular rate is 40 beats per minute. Our P waves are round and upright. Our PR interval is going to vary because the QRS complexes do not always follow a P wave. Our QRS complexes are about 2 small squares. Multiply that by 0.4 seconds, gives you 0.8 seconds, which is within normal limits. Our ST segment, there is some slight depression that you can see. Our T waves are not peaked or inverted, and our QT interval is around 8.5 squares. Multiply that by 0.4 and gives you 0.34 seconds, which is within normal limits of our QT interval. Our interpretation of this strip is going to be third-degree AV block. Causes of a third-degree AV block include congenital problems, MI, coronary artery disease, digoxin toxicity, calcium channel blockers, beta blockers, or surgical injury. Signs and symptoms are serious. There is fatigue, dyspnea, chest pain, lightheadedness, changes in mental status, pulmonary edema, loss of consciousness, bradycardia, diaphoresis, and changes in the intensity of pulses, because remember, our ventricular rate is not sufficient. Our P waves are not talking to our QRS complexes. Our atria are not talking to our ventricles. So the ventricles are beating just whenever they get an impulse. The treatment is going to be to improve the ventricular rate. We can use atropine, dopamine, or epinephrine. They might have a temporary pacemaker, and then long-term, they might need a permanent pacemaker. Treatment of dysrhythmias vary depending on the dysrhythmia, but it can consist of medications, cardioversion, defibrillation, pacemaker, or a combination of these. Medications include cardiac glycosides, antidysrhythmics, beta blockers, calcium channel blockers, and anticoagulants. Remember, you need to monitor the EKG rhythm, pulse, and vital signs when giving these medications. Cardioversion or defibrillation. Remember, cardioversion and defibrillation are different. Cardioversion is when there are synchronized shocks, and defibrillation is when there's a random electrical shock. And a pacemaker can either be external or internal.
Let's start by learning how to perform cardioversion. Here's a patient I recently treated. He was 57 years old. He had
He had
palpitations.
palpitations.
He had a
He had a
normal
normal
blood
blood
pressure.
pressure.
He didn't have
He
any
didn't have any
chest
chest
pain or
pain or
shortness
shortness
of
of
breath,
breath,
but he
but
was
he was
really
really
uncomfortable.
uncomfortable.
We
We
assessed him to have atrial fibrillation with rapid ventricular response, and we confirmed it with an EKG. You can see that there are no P waves, and the heart rate is pretty fast and irregular. Let's cardioversion. After consenting the patient for sedation and cardioversion, place your pads and connect to the machine. Next, administer the sedative and wait until it takes effect. Since you're performing cardioversion, press the sync button. Then select the energy level and charge the machine. I recommend at least 100 joules in a biphasic machine for all rhythms. Depending on the size of the patient, I may just go up to 200 joules of biphasic energy. Once charged, make
Make
sure no one is touching the patient. As soon as everyone is clear, press the shock button. You'll see a brief contraction of the patient's chest wall muscles. And at this point, look at the monitor and see if you have terminated the dysrhythmia. After the cardioversion, the EKG is repeated and shows successful cardioversion to normal sinus rhythm. Because we used the short-acting sedative etomidate, our patient was awake and asymptomatic and ready for discharge within minutes of the cardioversion. Now
Let's
let's
look
look
at
at
the case that needs defibrillation.
For
For
defibrillation,
defibrillation,
there's
there's
no
no
need for
need for
sedation,
sedation,
since the
since the
patient
patient
is
is
unconscious
unconscious
and
and
CPR is
CPR
likely
is
being
likely being
performed.
performed.
So
So
select the highest energy
and
and
charge
charge the machine. Once
Once
it's
it's
charged,
make sure
no
no
one
one
is
is
touching
touching
the
the
patient.
patient.
This
This
is
is
the only
the only
time
time
the
the
CPR
CPR
is
is
briefly
briefly
stopped.
stopped.
And as
And as
soon
soon as everyone is clear,
press the shock button.
button.
You'll see
You'll see
a
a
brief
brief
contraction of
contraction
the
of the
patient's
patient's
chest
chest
wall
wall
muscles.
muscles.
Using the
Using
latest
the latest
guidelines,
guidelines,
continue
continue
CPR
CPR
for 2
for 2
minutes
minutes
before
before
checking
checking
the
the
rhythm.
rhythm.
So
So, a little overview. Cardioversion is used for dysrhythmias that have a QRS complex. It's called synchronized cardioversion because the shock is given during the QRS complex and not the vulnerable T wave. If a shock is given during the T wave, it can throw a person into a fatal rhythm. The patient must sign a consent form or give informed consent. They're given a sedative to decrease the pain unless they're already unconscious, and a shock voltage can range anywhere from 25 to 500 watts. Defibrillation is a random electrical shock which depolarizes all myocardial cells and ends the chaotic activity. This helps allow the SA node to regain control of the heart rhythm. Defibrillation is recommended for V-fib and pulseless V-tach only. The rest of the rhythms are cardioverted if needed. Paddles, usually we're going to use the large pads with adhesive now. They're placed on the right upper sternum under the clavicle and the left side under the cardiac apex. And it's very important that you say all clear before pressing the defibrillation button because we don't want any of the nurses, doctors, anyone that's helping to get shocked. Talking about pacemakers, there are 2 types of pacemakers. There's external and internal. An external pacemaker is used normally for a short-term basis. It can also be referred to as transcutaneous pacing. This delivers impulses to the heart muscle through electrode pads that are placed on the outside of the chest wall and the back, so essentially it's the same as the defibrillator pads. These pads deliver small electrical shocks at an adjustable rate in joule, which is the current in the milliamp. It can be uncomfortable, so it might require sedative or pain medication, and usually this external pacemaker is only used in the ER setting, because if it has to be used for a longer period of time, they will want to do an internal pacemaker.
Who is in a second-degree heart block. This patient, as you can see, has a heart rate of 30. They still have a pulse, but they're symptomatic, and so we want to treat them. We've tried some atropine on this patient. However, the patient doesn't seem to be responding to the medication. So we want to think about doing some cardiac pacing on this patient. And always with pacing, you always want to remember it's a very painful process for your patient. So if you have time to get an IV inserted, and give them some medication like some Versed or Valium, something like that, to kind of sedate them, that's a really great idea. Okay, so here again, we have placed the pads on our patient so that we can pace, and you also will need your ECG leads on the chest as well. Okay, so to run the pacer, very easy. You see that the bottom section of the defibrillator says pacer, and there's a series of a couple buttons underneath that we're going to use to turn the pacer on. So go ahead and let's turn the pacer on. Okay, and notice we have a rate that comes up at 60. That's default on this machine. If we want to increase that rate, and many places go up to about a rate of 70 to 80 to pace, we're going to go to 80, and then you want to increase the current, the button below. So go ahead and let's start increasing our current. And what you're looking for is a pacer spike to appear. And then there are some pacer spikes, and now what we're looking to see is we want to see a corresponding QRS complex after that pacer spike on each spike. We're going to keep increasing that current until we see a pacer spike followed by a QRS complex. And this is what they refer to as capture. Okay? Now, we would want to check to see if our patient had a pulse with that. And yes, they do have a pulse. We'd want to check in the femoral artery, not the carotid artery, because sometimes the muscle can spasm and lead you to misbelieve. So we're going to go up 10 more after we've reached capture. And there we are. We are pacing this patient. Now, this is a transcutaneous pacing. It is a temporary thing, and you would want to take your patient to the cath lab to have a transvenous pacer placed. So here again, your cardiologist would be in charge of that. But you've got the patient stabilized at this point. You'd want to check their blood pressure and prepare them for transport.
The previous slide talked about an external pacemaker, and now we will talk about an internal pacemaker. So an internal pacemaker is a battery-operated generator that initiates and controls the heart rate by delivering electrical impulses to the heart muscle via an electrode. There's also the temporary transvenous system that can be inserted in an emergency after they've been transcutaneously paced. And this is when an external battery generator is connected to wires, and that's threaded to the right ventricle through the subclavian or femoral vein, and the battery pack is outside of the skin. A permanent pacemaker is when the battery pack is implanted under the skin, under the clavicle on the right or left side. The battery pack usually lasts around 10 years with a lithium battery. There's different types of permanent pacemakers. There's the single chamber, dual chamber, and biventricular pacemaker. So the single chamber pacemaker uses a single wire attached to one chamber of your heart. The dual chamber pacemaker uses two wires attached to two chambers of your heart. And the biventricular pacemaker uses three wires, two of which are attached to the ventricles, and the third is connected to the right atrium. This is used to coordinate contractions between the right and left ventricles. Two modes of pacing can be used with pacemakers. There's the synchronous or demand pacing, and this means that the pacemaker only fires when it needs to. So if it doesn't sense a P wave or an R wave, or the heart rate falls below a set rate, then it will fire a pacer. Asynchronous or fixed rate pacing means it continuously discharges regardless if the heart is beating at that rate or not. Reasons why a patient would need a pacemaker: they might have symptomatic bradycardia, second or third degree heart block, congenital heart disease, surgical trauma to the conduction system, like in cases of open heart surgery, ischemic demand to the conduction system related to heart attacks, adverse effects of medications like beta blockers, digoxin, calcium channel blockers, or electrolyte imbalances, and specifically talking about potassium. Symptoms that a patient would exhibit prior to pacemaker insertion Dizziness related to decreased cardiac output and decreased cerebral blood flow. Syncope or near syncope related to that decreased cardiac output and decreased cerebral blood flow, and possibly palpitations. Diagnostic tests prior to pacemaker insertion includes cardiac monitoring, a 24-hour Holter monitor, digoxin level if the patient is taking digoxin to check for digitalis toxicity, electrolyte levels, and all of these diagnostic tests are trying to find the reason that the patient needs a pacemaker. What does a pacemaker do? There are certain terms that are specific to pacemakers. So sensing means that it senses the heart's own electrical activity. Pacing means the pacemaker's ability to emit an electrical impulse. And the goal of pacing is for the impulse to be captured, meaning the heart will contract in response to the impulse from the pacemaker. You'll see a pacemaker spike on the EKG, followed by a P wave if the pacemaker is atrial pacing, or followed by a QRS complex if it is ventricular pacing. Pacemakers are usually set to 70 to 80 beats per minute, but it's ultimately up to the provider. What problems can a pacemaker develop? Undersensing can occur when the pacemaker doesn't sense the heart's own activity and acts as if the heart is not beating on its own, so the patient might experience extra beats. Oversensing can occur when the pacemaker is too sensitive and senses that non-cardiac signals are heartbeats, so it fails to pace when it needs to. The patient will complain of dizziness, syncope, due to that decreased output, cardiac output. Non-capture can occur when the pacemaker delivers an impulse, but the heart does not respond. And also battery failure can occur with pacemakers. How should I chart about pacemakers? You want to list subjective and objective data from the patient. Most patients will carry an ID card that describes their pacer in detail. Ask the patient for this card and write down all of the information. And document any additional information such as continuous cardiac monitoring that you have the patient on, blood pressure, heart rate, pulses. How does the doctor check the pacemaker function? It's checked with a pacemaker magnet. It looks like a bar or a donut, and it's a very powerful magnet. The doctor or the pacemaker rep will hold the magnet close to or over the pacer box, causing the pacer not to sense the patient's own heart activity. So this causes the pacemaker to go into that constant pacing, and it allows the doctor to see how that pacer is functioning. This is why it's important to ask if the patient has a pacemaker before an MRI, because the MRI magnet can affect pacemaker function. What should the patient know about their pacemaker? Symptoms they should report to their doctor should be educated to the patient. They need to carry the ID card or wear a medical alert bracelet. They should know the manufacturer, model, series number, and implant date and the doctor that implanted the pacemaker. They need to be educated on how to check their own pulse. They should check it daily and report if it's higher or lower than the set rate of their pacemaker. Regular follow-ups are important. They need to see a doctor at least annually. Most of the time, it's more often than that. They also need to be aware of potential electromagnetic interference. So they do not need to hold electrical appliances close to the pacemaker. They should avoid transmitter towers for radio, television, and radar. They should avoid welding equipment. They can use microwaves as long as the microwave has appropriate shielding, which most of your newer microwaves do. They should take their ID card to the airport if they're flying, because they shouldn't go through the security magnetic checkpoint there. And on page 649 of your book, there is more information on patient and family education, and it has do's and don'ts on pacemakers. What nursing intervention should I complete if I have a patient with a newly inserted pacemaker? So they're on strict bed rest for 12 to 24 hours. They need constant monitoring of their heart rate and rhythm, vital signs and level of consciousness, monitor the insertion site for signs and symptoms of infection and the dressing for bleeding. And they need to be taught to avoid raising the arm on the pacemaker side above the head and lifting more than 10 pounds for 4 to 6 weeks after pacemaker insertion. So that is all I have for part 2 of dysrhythmias. If you guys have any questions, feel free to reach out to me on Teams, and I look forward to seeing you guys at the Q&A.